This video will be demonstrating our Physeal sparing MPFL and MPTL reconstruction technique. We first draw out our incisions over the anterior patella and medial femoral condyle. An incision is then made over the medial patella, and dissection using electrocautery is taken down to bone on the medial aspect of the patella. A rongeur is then used to trim away bone edges to provide adequate surface for placement of our anchors. We then proceed with our incision over the medial epicondyle, and dissection is taken down to bone using the Metz scissors. After adequate exposure, we then proceed with placing our guide wire over the medial epicondyle at Schottle's point. This is done under fluoroscopy using the APN lateral views. You want to make sure you're aiming distal and anterior to avoid breaching the intercondylar notch or any injury to the physis. These views are showing that here. Our soft tissues are then retracted, and we proceed with drilling our tunnel over the guide wire. We measure the depth of our tunnel using the suction tip to be approximately 20 to 25 millimeters in depth. To allow for visualization, we clean our tunnel edges by placing the suction tip within the tunnel and cleaning the edges of the tunnel with electrocautery. We then proceed with placing our soft looped tensioning anchor into the tunnel of the drilled femoral condyle. The graft is then passed through the loop of the tensioning anchor, and it is then tensioned down into the tunnel. After the graft is tensioned and pulled down into the tunnel securely, the looped end can then be cut, and hand-thrown sutures using the knot pusher can be used to over-tie the graft in place in the tunnel. A biocomposite interference screw can then be placed in the tunnel to provide further fixation of the graft. The two ends of the graft are then shuttled up to the patellar incision between the capsule and soft tissues using a Kelly. We then proceed by placing our anchors into the medial aspect of the patella. The drill is used, and our soft anchors are malleted into place. The most inferior anchor is aimed in a superior direction to allow for fixation of our MPTL graft. Stability of the first anchor is checked, and placement of the second anchor is done in a more inferior aspect on the patella. The knee is brought into approximately 20 degrees of flexion by moving the triangle distally. The graft ends are then passed through the looped portion of the tensioning looped anchors and fashioned into place while the patella is well reduced in the trochlear groove. The superior anchor is tensioned, followed by the middle anchor. We then proceed with placing our most inferior anchor for the MPTL graft. The anchor is aimed superiorly at the inferomedial aspect of the patella. We then move to the proximal tibia for placement of our anchor in the epiphysis. The location of this anchor is approximately 1 centimeter distal to the medial tibial eminence as seen in this x-ray. The anchor is placed here after an incision and dissection is completed down to bone. The drill for our anchor placement is confirmed with fluoroscopy prior to drilling. The anchor site is cleaned from any soft tissues using electrocautery to allow for a secure fit of the graft down to bone at the anchor site. The anchor is placed in standard fashion at the proximal tibia. The second graft is used, and one end is placed through the looped end of the tensioning suture anchor and secured down to the anchor site. As previously completed, the graft can be shuttled up to the incision site of the patella and secured to the most inferior previously placed anchor. Incisions are closed in standard fashion. The wounds are dressed with soft dressings followed by bilateral TED hoses, and a hinged knee brace locked into extension is applied. We have all of our patients follow a standardized post-operative physical therapy protocol. Thank you.